I'm Dr. Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery in Sydney, and welcome to this video on the stromal transplant in detail. So the aim of this video is to show you details of exactly how I do it. This is relevant to people who just want to know. There are some very inquisitive patients who want to see it all and understand it, but more relevant to people who want to understand how to do it, that is surgical. Nursing staff and surgical assistants may also want to know. So I hope it's helpful to all of you. So to set the scene, I'm doing this surgery on a patient who has macular dystrophy. This is an inherited dystrophy, an inborn error, and you'll see white deposits. The cornea goes white, and this person is legally blind. The thing about macular dystrophy is it extends to all layers across the cornea, including the cell layer. You might ask, well, why not do a full transplant? Because these patients are young, and to replace the cell layer means to commit this person to a life of corneal failure and rejection with all the other problems such as glaucoma, etc., that inflict people who need a revision transplant. The possibility of a degradation of vision from the residual macular dystrophy is not insignificant, but it might drop them one line or so. I'd lose a line of vision to have a transplant last me most of my life, and hopefully all of my life. I think that's very worthwhile. And this patient has had a layered transplant in the other eye and sees 20/20. So he's really happy. I also operated on his sister and she sees 20/20. She's really happy. Finally, the thing that this tissue allows is that because it is opaque, it's easier to see the dissection. So it makes it easier for the viewer because you lose a lot when you go from 3D to 2D. Also, the tissue is quite stiff and it's thinned, and it's the thickness, the rigidity of the tissue is pretty constant all the way around. And because of that, I can use a continuous suture. In ectasias, keratoconus, the host tissue varies. Sometimes I have to put interrupted stitches in, but in this case I put a continuous, and it works well in macular dystrophy. So I hope that all makes sense. I hope you enjoy it, learn something from it. Leave a comment, send a message. I'm Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery in Sydney.
This is a video of stromal transplantation to restore vision in macular dystrophy. You'll see here a cornea with quite diffuse macular dystrophy centrally, and this vision has dropped off to count fingers. The patient has had surgery on his other eye some 7 years earlier, so now he's elected to go with this eye. What I'm doing is measuring, and I'm calibrating the measurement against a ruler because calipers are notoriously inaccurate, and here I've come down to select an 8mm caliper, an 8mm diameter, I'm sorry. This is a Moria disposable trephine, and this Moria trephine is set to 300 microns. So I trephine down to 300 microns. You'll notice that when I take it off, it leaves a ring around the sclera. That's because it sclerally fixates. It does not fixate on the cornea. Next, I have to make an insertion into the eye, and this insertion is behind the limbus. So it's a paracentesis behind the limbus. The benefit of this is when I put a bubble in the eye, the bubble rises above the opening. The downside is blood gets in the way. Everything has a cost. So here I put a bubble of air in the eye so I can see the posterior surface of the cornea. Once I do that, then I do a freehand dissection as deeply as I can. It's very tricky to see here because it's actually quite a thin cornea. Macular dystrophy corneas are quite thin. They're also very rigid. You'll see that the dystrophy extends not just through the stroma but into decimes. So there's always going to be a little compromise, but I think the price of keeping the endothelium is worth it. Once I get there, watch how I struggle with the initial dissection down to decimes membrane. I do go to pre-decimes plane rather than purely decimes membrane because I do not wish to rupture the eye. I haven't ruptured in more than 15 years using this technique, and I think functionally there is no difference. So here I'm struggling to get down there, and so I take my time and just find it plane under direct vision. It's very easy to do under direct vision. It's very hard to do indirectly, and here you go. I sorted a plane. I move on to the second dissector. It looks a bit vigorous, but in fact it's not. And once you find it, it slips right through. Now I'm not in my final plane. However, under direct vision it's easy to find that. I keep going, opening up the cornea peripherally. I call this technique conquering the mountain. It's a military strategy. If you want to conquer a mountain, you don't run right up to the top, you surround the base. And what I'm doing here is surrounding the base of the mountain and then going to proceed to the top. Again, keep dissecting until the limits of your hand movements. You'll notice here that I change hands. It's a very important part of the whole process. If you're going to do this sort of surgery this way, it's much easier if you are ambidextrous or teach yourself to use both hands. We are naturally ambidextrous, we just tend to focus on using one and then discarding the other. So here I go, just once again now to the other side of the dome, going all the way around. I try to do this as quickly as possible, and you'll see in a minute why I do it as quickly as possible. Here I go, all the way around, and going. And once I get to a point where I think my hands are at their comfortable limits, I do something different, and watch this. The air bubbles in the eye, and air is toxic, so I make a point of exchanging the air for saline, leaving it for a moment and allowing the endothelium to have a drink. When I do this, I lose hardly any endothelial cells. So now I put the air back in and I can continue. Notice I haven't gone all the way down, so I keep going until I get to where I want to be. You might think it takes a little bit of time. It's a much safer way to do it. And if it adds 15 minutes, so what? You can get a much better outcome for the patient. Once again, I now change to the finer blade, and this allows me to really, it's not sharp by any means, and using feeling you can actually find your way down to decimase, to pre-decimase plane. And it's a matter of just continuing all the way through. It's patience, it's quite meditative, but you just keep going. You get to a point where you can start to see the deep decimase, and you know that you're in a comfortable zone now, and now you can do it all under direct vision. Also note how I dissect under the host tissue. It's important not to dissect up to the graft-host junction, but under the host tissue to which you're going to suture, because that's where your sutures are going to be placed. Notice here I can see I'm not down far enough, so I pick up my first blade again and go again. Here we go, right under the wound. It's the trickiest place under where you start. And I just go back and forth until I get to where I want to go. Traction on the cornea is really important. I've gone straight from the first blade to the third blade here. Traction on the cornea helps keep everything separated. And I keep going. Patience is everything here. Take your time. There's no rush. Now, if you leave a little bit of stroma in the periphery, so what? It's not granular dystrophy where recurrences can occur. Notice I'm now giving the endothelium a drink again. It's time for the endothelium to have another drink. Please note this is playing at 1.5 speed, so I don't bore you with waiting. But it's not double speed, it's 1.5. Back again, I put more air in. Endothelium's going to be happy now. And with difficult cases, you've got to keep doing this a number of times. There's no set times, just every few minutes. If I spend a bit of time, I think, let's give the endothelium a drink. Here you can see now I'm using my left hand to come backwards. Whichever plane opens up is the plane you follow. People often ask me, oh, how do you get to the plane? You don't, you make it. It's like making your own track through a forest. If there's no track there, you make it. And soon everyone can follow. Again, find that plane. I'm using my left hand. I'm going under the host tissue in a sweeping motion. It's sweeping as much as it is pushing. Notice I don't have to hold the whole eye. I can grab the tissue as I need to be comfortable to do the dissection. Again, now once I changed hands, I can keep going. See this curved sweeping motion? I don't push as much as I sweep. And there we go. You can see it's quite thick, the residual tissue there, but now I'm getting a very clear view of the pre-decimase plane. So this is where I want to be. This is exactly where I want to be. Again, sweeping motion, follow it all the way through. Again, change of air. Here we go. It's as it swells up, it can be difficult to enter. You've just got to take your time, find the entrance point. You can see the decimase membrane folding now as the eye collapses under a deflation of the anterior chamber. Picking off the tissue now, you can see, finally I'm getting to where I want to be. I started from the superior aspect where I saw, okay, that's where I want to be. Now I pass backwards. Again, if there's a little bit of tissue peripherally in a macular dystrophy, it doesn't matter with a stromal transplant. You can tidy it up later with the endothelium under saline, and you've got time. Don't leave air in there indefinitely. You will kill off the endothelium and end up with cell counts under 1,000. So here I go again, traveling backwards, so layer by layer until I get to the pre-decimase plane. Going around, notice the eye moves out of the screen at times and you are pushing the eye. It's very important not to push the head, and sometimes you have to recenter. Again, just use the sweeping motion of the dissector and it literally opens up. Once you're in the pre-decimase plane, it becomes easier. The dissection becomes easier and it literally just peels off. In that little pause there, I exchanged more saline for air. See how it just peels off? Sweeping motion, sweeping motion. You cannot use an air dissection technique. This disease process goes all the way through to decimase. You will rupture, and then you're finding you're doing a full transplant and wasting time and getting frustrated. The price you pay for this is there's residual macular dystrophy in the decimase membrane. You can't get rid of it. Patients' visions come up to about 6.9 or 6.75. I've had one come up to 6.6, but that's unusual. I think that's a very good price to pay in a young patient with looking down the barrel at a lifetime of a full transplant and multiple regrafts. 6.9 vision is more than adequate to do most functions of life. No patient has yet not thanked me. Dissection continues. Go as far as you can, and you can see it's now looking clear as we get into the central part of the cornea. Get this as clear as you can. This is where vision happens. And you can see, you just push it away. It literally peels away. There's hardly any force here. It becomes easier as you progress. Don't get too gung-ho because you'll rupture, and then in these cases ruptures usually don't move, but it's much harder to dissect once you've ruptured. It's much easier when you haven't. At this point you can go right out to the periphery and just remove it, and then proceed to a tidy up of the central zone. It's easy to dissect this portion that's far away from your hands simply because you're doing it from the top down. Very hard to do it right from the sides. Using direct vision is always better. And there we go. Cornea comes off. I always send it to pathology even though we know it's macular dystrophy. Patient likes to see a pretty picture. You can clear up anything centrally. I use the little red blade to do that. And we've got a lovely clear cornea. Note the little deposits in decimase membrane. They're not going to go. The only way to get rid of them is to remove decimase. I oversize a little bit. usually 1/4 ml, particularly in this case where the cornea is quite rigid. Again, use a Moria, this time on an artificial chamber, go straight through. The Moria is beautiful, you don't have to worry about vacuum, it produces a beautifully elegant punch. The tissue is usually thicker than the host tissue. Here you see I'm wiping off all the viscoelastic on the cornea just in case I did perforate. Vision Blue, which I wonderfully squirt all over the eye so that it stains Descemet's membrane. Not something I intend to do, but it won't harm. I use a double staining approach, so I put some down, and then this is not a really good quality cornea. Endothelial cells aren't happy, so look how beautifully the endothelium stains. It goes bright blue. I'm glad I didn't have to use this for a full transplant. And here we go. Slight oversizing, as I said. I always use cardinal sutures. These are removable sutures. I don't leave cardinals in place. I use 8 routinely, not 4. I was taught to use 4, but I always use 8, and I make sure that it's sitting as I want. This is one of the huge advantages of a stromal transplant. It's much easier to get alignment when the eye is formed. When the eye is not formed and opened, all the tissue collapses on itself. It's very hard to get alignment. Note how easy it is here. So there's my final 1/8, and I've adjusted them. So you don't just put them and leave them, you put them and you remove them, replace them so that it looks beautifully symmetrical. Try to space them equally, both radially and tangentially. Keep it as orthogonal as you can to exert the same tension. This is much easier in a macular dystrophy where the host tissue is pretty much the same. It's uniform all the way around. In a cone, the tissue changes. Here I'm starting my continuous suture, which in this case I think macular dystrophy does very well with the continuous suture. And you just keep going around. How you do this is an art in itself. Not really the subject of this video. Notice I'm going in the interface. Don't just place it in the stroma. You've got to go deep into that interface. Find the interface. Note also the eye's full of saline, not air. We want to keep that endothelium happy. Go all the way around, tie it up, and once you get here, I do two loops. So I don't do 3, I do 2. I tension it first, then I do 2 loops. Here we go with the tensioning. Tension the other side. You don't have to make it overly tight. And then here comes the key. 2 loops. And there we are. So the next thing is important. As I said earlier, I remove the cardinals. That's why I've left them on a long string. Easy to just pick them up and remove them. There it is, gone. Don't cut your continuous, which I certainly have done on more than one occasion. So here comes the next trick to get good refractive outcome. And this gentleman had 2D of SIL post-op. Very happy patient. So once you do that, here's the next bit. Wiggle. Wiggle the graft. Let it find its place. Don't just leave it there. Wiggle it. Now you can retension it and then close. So I've wiggled it so it has that beautiful cartwheel appearance. Now I retension the suture. There we go. Now I tie it off. And I cut the suture with a blade. Everyone likes to use scissors, but blades are disposable. Scissors aren't. Let's keep our scissors for when we need them. And that's done. Here's my keratoscopy. Nice and round. There's a bit of epithelial irregularity there, but nice and round, which is why he had 2D of SIL. And that's how I do my stromal transplants, before and now, after. And I don't see these patients for 2 weeks. They use drops post-operatively, and by the time I see them, they're healed. Thanks everyone for watching.